And
Join Dr. Coffee Brown to discuss what's new in health and medicine. Dr. Brown and his guests explore the latest research and technology in health and medicine and help us understand how it affects our lives. Then they provide takeaways and steps we can take to improve our own health in the future. We're glad you're here to take part in the conversation.
and
In this episode, Dr. Coffee Brown's guest is Dr. Paul B. Roth, MD. Dr. Roth is Chancellor Emeritus for Health Sciences and Dean Emeritus for the UNM School of Medicine. He is a founder of the UNM Center for Disaster Medicine and created the nation's first civilian disaster medical assistance team. Notably, Dr. Roth led a disaster medical assistance team following the 9/11 attack in New York. Thanks for joining us today, and now back to our host, Dr. Coffee Brown.
Thank you, Shelley. My name is Dr. Coffee Brown, and I trained at University of New Mexico for my residency in emergency medicine, and later on worked there as an educator for the last 13 years or so. So for a large chunk of my career, I've known Paul Roth as boss. Most people in Albuquerque will know Paul Roth for his role as a chancellor. But a lot of what made me want to do this interview today is that I know Dr. Roth in a very different context. I met him as a working clinician. He was one of my earliest professors and a very profound positive influence on me. I hope, Paul, that you feel that your mentorship, that you saw that in action again when I became a mentor later on. I hope that you were happy with how that turned out. Paul also pretty much invented urgent cares and is one of literally, you could count them on one hand, a handful of people who started what's now a subspecialty in emergency medicine called disaster medicine, which is today's topic. What is disaster medicine? Why would you want to know that? How did it get born? And, what's it like to do that? Life for someone like Dr. Roth isn't always in an office meeting with bigwigs. When disaster medicine started, he traveled in a tiny, I think, 2-engine plane, right, into hurricane territory. And, well, let's let him tell it. Paul, how did you get started? What made you think to start disaster medicine, and how did you get that going? What is it?
Yeah, so that's, as you know, I was boarded in emergency medicine, worked at the University of New Mexico Hospital for many years. And initially I had never even thought about disasters or disaster medicine. But in the very early 80s, under the Reagan administration, the federal government felt that it was important to create a response to domestic disasters that would not tie up the military. So up until that point, if there were disasters within the United States, FEMA would very often have to draw on the military to respond. And that would be okay for small things, but the other concern from in Washington was that if there was a disaster, a major disaster, that it would tie up our military and that our enemies across the globe would take advantage of that, and it would compromise our ability to defend our country. It was also just a couple of years earlier when there was something called the Great Alaskan Earthquake. It was a huge earthquake. Fortunately, not too many people were affected because Alaska then and still is somewhat of a wilderness territory. But since Reagan was governor of California, his concern was, well, what if California and the San Andreas Fault really suffered the same level magnitude earthquake as Alaska did? And so he sought the advice of many people, and FEMA was in existence at that time, and had been for many years. And so he pulled together a group of people and began working on a more formal disaster response for domestic events. And out of that came what's called the National Disaster Medical System. And the plan initially was to identify 50 cities in the United States that would have a nearby international airport that would carry, would handle C-130s, the military's major cargo. And personnel are considered cargo in the military, and someplace that would allow for that type of transport. And so the head of NDMS visited Albuquerque, and it was in the early 80s, maybe 81, 82, somewhere around there. And he asked to convene leaders in the emergency medical services, both hospitals, doctors, EMS, as well as city, state leaders, government leaders. And we all convened in the basement of City Hall. And there were several hundred people there. And so the director's name was Tom Rudershan. He was the very first director of National Disaster Medical System. And after introductions and his explanation of what the NDMS was all about, he said that he was looking for somebody to take the lead in developing a civilian disaster team called a Disaster Medical Assistance Team, or a DMAT, in New Mexico. And so I began. Nobody actually raised their hands. The hospitals really didn't. They wanted to get involved with anything like that, and the rest of the physicians were very busy, and city and state government had their jobs. And I had thought, well, wait a second now. Disasters would be just a lot of emergencies, and I'm an emergency physician, and it sounds like something that emergency medicine should get involved with. And so I raised my hand, and obviously I didn't have a lot of competition, so I was selected to take the lead for NDMS in New Mexico, and specifically to help develop these disaster teams.
In fact, for that reason, we're DMAT 1, right?
We were a DMAT 1. Our official name was New Mexico DMAT. It was a very different, obviously things change. And in the very, very beginning, the National Disaster Medical System was really composed of two major parts. It was a hospital system that prior to that time, it was known as CHMCHS, the Civilian Medical Hospital System. And that system was designed in the event of a war. and where military casualties would come back to be transported back to the United States. And if in the event that there were so many casualties, it would overwhelm both the DoD and VA resources, then the default would be civilian hospitals. And so this system had been in place for many years. I'm imagining way back from the 50s, and with the concern of war with Russia and with other players around the world. And so they converted that CHIMCHIS hospital response and grouped it into a hospital response in the event of a disaster. So if there were overwhelming casualties somewhere in the United States that overwhelmed local and regional resources, they would transport victims to other areas around the United States.
And in fact, I think as part of that military readiness, by the way, that's the same place that we got our interstate highway system. It was funded on the grounds of military readiness, and the structure of medicine, the sort of officer and enlisted kind of structure that medicine had at that time, was based on the emergency preparedness model, if I understand correctly.
Yeah, that's right. The interstate system was developed in the Eisenhower administration, and it was specifically intended to transport people and supplies from one end of the country to the other in the fastest possible way. And obviously we use it for many, many different reasons now. Yeah, so the first DMAT, we were the first DMAT, and each DMAT was set up to have a sponsoring institution. And our sponsoring institution was UNM Hospital. And so we would have the availability of using space. And it was really the whole University of New Mexico. At that time, we did not have a health sciences center. It was called UNM Medical Center. And within the medical center was UNM Hospital and the psych hospitals and the medical school, and that was it. So we were able to use all of the resources of the medical center, UNM Medical Center at the time. And so I would go around the state and visit with people and begin trying to promote the disaster team concept. Eventually we would, and this was all voluntary, we eventually got people from all over the state. We ultimately got well over 200 volunteers, and it would range because each of these teams have to be self-sufficient. And to be self-sufficient, you just can't have just doctors and nurses and pharmacists. You need people that would be expert in logistics and communications and security and an administrative structure so that you could operationalize these systems of disaster response, and people that would be able to maintain the space, the kinds of areas that the medical team of the DMAT would be working out of. And so
the complexity of arranging all that just boggles my mind.
Yeah, it was a major effort. And of course, and the idea for these DMATs then and still today was that whenever the team would be deployed, that the team would have to be completely self-sufficient for at least 72 hours. Usually in a setting of a disaster, it's very hard to get there. And once you're there, it's not very likely that you'll get resupplied for at least 3 days. And so we would have to bring our own, we would have stashes of supplies on big pallets that would consist of not just the obvious medical supplies, but food and tents, communication gear, all of that. And so we had on our team, usually the size of the team would be somewhere around 32 to 38 people, and it would consist of several logistics people, security, administration, and then obviously the full array of a medical team.
Yeah, and security is no minor consideration. And some of these sites, for obvious reasons, there was a real risk of them being raided for supplies by, starving people in disaster zones.
Absolutely. When we went to southern Florida after Hurricane Andrew, which was a devastating hurricane for that area, there was one. We were based in an area that was known for drug trafficking. And we were the only standing facility. We had to convert a small community center into a medical area. And that's also where food supplies were staged, water, and then medical. We were the medical part. And it wouldn't be uncommon that we would hear gunshots. And we were the first ones prior to that time. The concept was that you would maintain a stationary unit, and you would have people come to you who would need medical aid. We discovered that in that particular area of Florida, there were a lot of seniors and people who were we felt unlikely to actually be able to get out of their homes and get to where we were. So we set up small units consisting of a doc, a nurse, and at that time, our security was provided by National Guard. And it would be that 3-person unit would go to communities, neighborhoods around our area that we were responsible for, and knock on doors and check to see if there were anyone within those areas that really needed some help. And they would carry supplies and medications with them in order to provide some initial care for those folks that couldn't make it out of their own home.
I'm thinking about the flood in Florida. I'm trying to remember the name of the location, name of the hospital, where they couldn't get people out. They couldn't move people at all and had to make some just horrifying decisions on site, illustrating what you're talking about, that not everybody can go to the place where there might be help for them. And so that was an unforeseen element. So you created what are called strike teams, I believe. Is that right?
Well, we didn't actually call them much. We didn't have a name for them at the time, but it was the first time that we would have something like what you're describing that would then be reaching out to people rather than simply passively remaining stationary and accepting victims as they were able to make it to our location.
So I was in DMAT for a little while, much later, and by then we had, tents and everything was really worked out and stuff. Compared to what you did, it was practically like being in a hotel. What kind of resources did you, and what kind of preparation did you have? You can schedule these disasters, right? So you plan them ahead on your calendar.
Oh, of course, yes. Well, you know what? I think you understated. Even for today, while there are much more high-tech tents and supplies, it's still pretty austere conditions when you have to go out into a location that essentially has been devastated. There's no services, no facilities available for backup, and it's really not like a hotel.
No, it's not.
When you
No,
were
it's not.
Yeah,
Not even now.
you couldn't even call room service and have somebody deliver your food. It was all improvising what you needed to be done most of the time. So the very first deployment for a disaster team in the United States was following Hurricane Hugo in the U.S. Virgin Islands in the Caribbean. And we were the only fully trained and organized disaster team in the country at that time. And so we were federalized and deployed and arrived on St. Croix about close to 2 weeks after the hurricane. And at the time, the governor of St. Croix of the U.S. Virgin Islands really didn't want aid. I think he felt it was dishonorable and that they could take care of themselves without having to call on the rest of the United States for support. But ultimately, when things really began deteriorating, the hospital, the single hospital on the island was completely destroyed. The ability to have potable water on the island, they would have to have desalination plants, and those were destroyed. So there was no water, there were no medical facilities. Literally, there was nothing. There was no public services, no electricity, nothing. And in fact, those members of the medical community that had been on the island evacuated before the hurricane hit the island, and they couldn't return. So it was a place of absolute destruction without hardly any of the existing support systems that the island and those living on the island were dependent on.
You mentioned something interesting there, Paul. The reluctance to accept help for reasons of pride, basically. And we saw a lot of this during the pandemic. We've seen it with some of our mass shootings and floodings. People either reluctant to give or to get help at times when clearly the population needs it. And it surprises me because in my mind, the most positive moments that a community ever experiences are when we're helping each other. Why would we pass that up? Why is that not something everybody sort of leaps to? I literally don't understand why anyone would pass up the chance to help their neighbors, because I mean, look at us. We're talking about this thing 30 years later and how meaningful it is, right? It's the kind of thing that makes you see yourself in a more positive way the entire rest of your life. And when you get help from your neighbors, you feel very differently about the world than when they're sitting back and experiencing schadenfreude at your misfortune. And yet, somehow, during the pandemic and during some of the flooding that's occurred in the last decade or so, I feel like it sometimes it's pulled us apart rather than together. That's one of the reasons I'm such a fan of DMAT, is because of it represents that kind of value to me. What are your thoughts about that?
Yeah, I found that to be very surprising to me too. Now in New Mexico historically, as a state that was founded by pioneers, essentially, and people who would and indigenous communities that had been here for hundreds and hundreds of years. All our history is more connected to neighbor helping neighbor and volunteers, which would be a natural thing for us. And as you know, in New Mexico, the EMS system started off 100% volunteers. At a time when there weren't even paramedics, you would have somebody who would be in a small community in New Mexico who would be the mayor and the fire chief, and it was all that kind of culture where neighbors would be there, very forthcoming in the event of a community need of any kind, really. And that kind of spirit is actually why our team was the largest DMAT in the United States, and how I was able to pull so many people in such a short period of time, because that was the whole premise. All of us coming together, getting trained, and prepared at a moment's notice to be transported across the United States in an effort to lend a helping hand to people who were really in desperate need. And when you talk to individuals, or when I spoke to individuals in the different natural disasters that we all responded to, they were extraordinarily appreciative. And if they had any questions at all, they would ask, well, how come you weren't able to get here sooner?
Yeah.
And so I found that it was mostly the politicians who felt somehow that they would lose face, or I'm not exactly sure very much about what the psychology was or would have been in them not wanting aid as quickly as possible. But it was a phenomena that we not only saw in St. Croix, but there had been a reluctance even in earthquakes and hurricanes in the Southeast, in other situations when there had been after several years of the NDMS, the whole system became a lot more sophisticated, as you would imagine. And if they developed a routine where if there were a forecast of a major hurricane, obviously you can't forecast earthquakes, but you can forecast hurricanes, that the feds would create these staging areas where they would pre-position, usually not people so much, but supplies, in a region that would be just outside of what they would have predicted to be the path of a hurricane. And so they would have a shorter transport time to get those supplies if they were needed to a site of a major disaster. And even at that level, I remember maybe it was Katrina, where the governor in Louisiana really didn't want the feds to be in his state, even for pre-positioning and staging these supplies. And it was very similar. I had the same feeling then as I did with the governor in the U.S. Virgin Islands, not really wanting to admit that they couldn't manage themselves or take care of themselves, that was some kind of a slight to their leadership somehow.
So you went out there. You had what kind of facilities did you have when you went to St. Croix?
Well, we were supported by a U.S. Army Reserve medical unit out of, I think it was Alabama or Georgia. And they were able to transport a MASH unit. So they were able to set up a hospital in a tent and there were no medical personnel. It was just the team that created that structure for us. The hospital was destroyed, and we were still dependent on the federal government for our personal tents. We didn't have the kinds of supplies that we eventually were able to develop. So we had canvas tents, and they were on site, but we had to put them. We had to put them together. So we ultimately constructed these large military canvas tents, which we really didn't have any experience doing, but we figured it out nevertheless.
Yeah.
And what was kind of funny, although it wasn't very funny at the time, was that while we did bring a lot of our own gear with us, we were told that the NDMS would provide some boots for us, sleeping bags, and some other supplies, that there would be some food there stashed away for us. We still brought all of the stuff that we felt we needed anyway, fortunately. And so the boots that we wound up having access to were all size 7 Arctic boots. And of course, this was in the heat of the late summer in the Caribbean, and it was hot, really hot and humid. And our sleeping bags were winter sleeping bags. And the only food that we found were canned sardines. And I don't particularly care for sardines, even on Caesar salad, or in any other meal. So it wasn't much of a support from my perspective. But this was the first time the feds were actually able to create a response to a disaster too.
And I like what you said about it. You mentioned that they brought you this MASH tent. I was thinking a little earlier before our talk today about the similarities and differences with a MASH unit. For people listening, think Alan Alda in the old MASH TV show, about that level in a lot of ways. However, there aren't individual skirmishes. These things can drag on for days or weeks without break. It's not all the same kind of injury. It's not all explosives and penetrating trauma. It's every kind of medical thing that can happen, a much, much broader array of patients. And it's men, women, and children, for some of whom nutrition, for example, is the major problem. So it's much less limited in scope than a MASH unit, and yet it's impossible to prepare for every eventuality. I'm aware that DMAT has gotten more efficient at planning for most likely eventualities, but being inventive is clearly one of the hallmarks of being on a DMAT team, I think.
Oh, absolutely. When we were on St. Croix, we delivered 5 or 6 babies. We did not have an obstetrician with us. We did have a pediatrician, and we had several primary care doctors, a couple of family medicine doctors. So we were able to, and we had several nurses who were pediatric nurses, as it turns out. So as you said, and then what's interesting in a disaster, it's only, there is somewhat of a literature, more based on experience in the medical literature, about the kinds of medical conditions that you would need to be prepared to manage by days following the disaster. And so, as you might imagine, within maybe 5 to 6 days, 7 days, the first week or so, you're dealing with more acute injuries. So crush injuries or broken bones and lacerations and those kinds of things. But then gradually, as in almost all of the communities, well, that we can think of even in New Mexico, people have chronic medical conditions, so diabetes and congestive heart failure and other medical conditions for which they need regular medication. And if there were no drugstores accessible, those medications would soon run out, and you would have to be prepared in weeks 2, 3, and 4 to start taking care of and having the ability to have medications with you and assess people whose diabetes were beginning to get out of control, their heart failure perhaps not being managed properly, and other medical conditions that would be quite different than what you would be expecting immediately after a disaster.
Yeah, things that are not a direct effect of the disaster, but an indirect effect caused by the failure of the infrastructure. For example, if we were to have such a disaster now this week here in Albuquerque, heat stroke would become one of our major problems because people wouldn't be able to get, air conditioning anywhere.
Right. Or water, even
Or
as
water.
basic as having real drinkable water. And dehydration and heat exhaustion. It would just all those things that we still do see even when we have our infrastructure fully working. But there would just be much more of it, and exposing people to kinds of risks that you just wouldn't be seeing normally in any kind of a third world or industrialized country.
Now, two things that spring to my mind while you're saying this. One is that, a lot of people at least have the general idea that they should keep some food and water around in case of interruptions of supply. They may do it or they may not, but at least they're aware of that concept. But a lot of people are not aware of the advisability of staying a few weeks ahead on medications. They don't sort of realize that that can be disrupted at any time. And it creates a cascading chain of problems and disasters. But even once you get that far, we have quite a lot of people in our area here in New Mexico, the state of New Mexico, who simply wouldn't be able to afford to store extra food. Water they probably could, but maybe not have appropriate containers and so on. And of course, storing medicines a few weeks in advance, just getting your medicines on a day-to-day basis is prohibitively expensive for a lot of folks, even if they're on Medicare and Medicaid. So I think that disasters highlight in quick time underlying problems that are present all the time, like the way that the pandemic brought out the real consequences of healthcare disparities. We're not talking inconveniences, we're talking death, different groups dying at different rates as a direct consequence of socioeconomics. I haven't seen any particular spirit to do anything about it, but at least we've been made more aware of it.
Yeah, that's a really important observation, Coffee. And even during the pandemic, in the very beginning, we were experiencing a disaster. So a disaster is defined as being any situation in which the medical needs, the serious, significant medical needs, overwhelm the capability of any region or local area's ability to meet those needs. And certainly this pandemic, we heard all kinds of stories in California, and even today around the world, in India, where there simply were not the kinds of resources available in order to just do basic management of people having pulmonary problems, not even having enough oxygen for people. And so it draws on a very old approach in triaging. So a triage a triage system. Obviously, Coffee, you know what this is all about, but for the listeners, a triage is a system whereby you categorize individuals following a mass casualty or in an ongoing disaster as in 4 different categories. And if you only had, let's say, what we had been discussing early on in the pandemic, remember there were concerns about not having enough ventilators. And fortunately, here in New Mexico, we never had to actually implement any of those kinds of triage protocols. But the planning around the scenario, what would happen in our hospital system here in Albuquerque, and in any individual hospital, what if we only had, a dozen ventilators that we had access to, that was available, and then suddenly over a course of a short period of time, there were 20 people that would come to the emergency room, all needing ventilators. What would we do? And beginning to think about that before it would actually occur was one of the great planning efforts here in New Mexico that was very well thought out. And we have to give a shout out to the governor for the effort here in New Mexico and being so effective in getting the right people together from the hospital community, medical community, and legal community to sort of prepare for the worst, hope for the best, but prepare for the worst. And what was really great about the leadership involved in planning for those terrible scenarios that we all felt still had to be planned for was that we had a group of ethicists. We had religious leaders. We had Native American leaders. We had doctors and nurses and people who were part of the community.
You may not know, but I was involved with that group, actually.
Oh, I didn't know that, Coffee. Yeah, so you can speak directly about the kinds of thought. How do you make that decision about who would be put on a ventilator and who wouldn't?
And not every place made the same exact pattern of decisions. They were all pretty similar. Bioethics works the same way pretty much everywhere, but there are some decisions you have to make, such as, for example, should age be a factor?
Right.
Should we conceal things like race and gender in order to prevent them from being factors?
Right.
Should a person's profession be a factor? And for example, one school of thought, and this is, bioethics writ large, this isn't like this group, it's in all the discussions, would be, should medical personnel be prioritized? An argument for it is we need to keep them in the system, especially for a disaster like this that can last long enough for some of them to recover and be returned to duty. And also, you don't want them unwilling to go and do their job. But on the other hand, would that amount to a kind of nepotism and have the exact opposite effect of what you want? Every single decision, and there's about between 20 and 30, I would say, division points. All of them are wrong from one perspective and necessary for another perspective. And this really highlighted that. And I will say that the panels that were involved, I was super impressed. I really liked the level of thinking, the level of selflessness, and so forth that went into the work that was done. It highlighted something else kind of interesting, which is that the pandemic committed the crime, or from the COVID's point of view, had the strategy to be boring. We're much more likely to do the right thing for an exciting emergency than for a boring emergency, as if the number of people who die weren't the important part of the story.
Right. Oh, absolutely. Yes, it was shocking to imagine a situation in which here in the United States, in a sophisticated medical community like Albuquerque, that we would ever have to face the scenario of having to deny care to anyone.
Well,
So,
that may lead us to the last thing we should talk about, Paul, which is we know that natural disasters will occur with increasing frequency. By the way, so will intercultural disasters as people hunt for water and arable land and things like that. Climate change is going to cause shifts on a scale we haven't seen since the last ice age, and that's going to lead to conflict. Um, knowing as we do for an absolute fact that the kinds of disasters DMATs were built for are only going to increase going forward, what sort of planning is happening around that right now? How seriously is leadership taking that?
yeah, so that moves us more into the world of politics. And, FEMA is part of Homeland Security. It had been part of the Department of Health and Human Services initially, but had moved over to become a division within Homeland Security. And what I always found amazing, or maybe not amazing, but disappointing, is that for each of the disasters that we had responded to, it was like rediscovering the wheel each time. So, as you know, Coffee, there's not like a unified communication system. So, fire departments would have a different system from police departments, and EMS often would be on a different one, and so something as basic as being able to communicate with all the rest of the responders was always lacking. And in spite of the fact that maybe a community might have saw the need for that in the past, never really mounting a response to address that concern or that problem going forward. And so you get into these situations, the logic really is that from a political point of view, usually the horizon for concern, and I don't want to be demeaning to politicians because I think there are many, many more politicians that have huge integrity and are there in an elected position for the right reasons than there are the fringe that we read about all the time. But ordinarily, the time frame that is often considered is the term of the elected official. So, for representatives, that's a couple of years. For senators, maybe it's 6 years. And so, and governors, it's 4 years, and presidents, it's 4 years. And so the whole strategy, the campaign, the kinds of planning that occurs oftentimes, not all the time, but oftentimes has to be done from their perspective within that term. And usually within for the president, the first 2 years, really,
Yeah.
when you lay out your platform. And there's not as much consideration about long-term needs. It's what's right in your face at the time that you're elected. You're in the position of being able to more or less redirect the attention of the United States, create policy, move resources, allocate effort. But it's ordinarily what's an immediate need and not a long-term strategy that plays out over multiple administrations. And so
And
what I
that's
found was each time we went to a disaster, we had very similar problems. They would never seem to be getting fixed. So it's not, I don't know what the current planning is. I'm hoping that there's a little bit more wisdom and a little less political views and perspectives that are being planned, and that there can be a more sustainable effort for maintaining systems and maintaining inventories that would allow the United States to be better prepared in the response, and then even in the recovery stage, being able to bounce back to a normal world even after a devastating disaster. Um, and so I'm hoping that that is happening, but my experience tells me that it may not. It may not be happening. So
you know, we need to stop being astonished every time a disaster occurs. We need to recognize that they're just like weather. You can't go outside and be astounded that it's raining. You might have forgot your umbrella that day, but you should at least realize that rain is going to happen from time to time, and disasters are like that. And I've noticed that if a bridge collapses and a politician goes out and makes sad noises and pronouncements and commits some of the money that isn't enough to get the bridge rebuilt, everybody goes, great job. But if that same politician had prevented the bridge from collapsing, nobody would have cared. Nobody would have even realized what he had done. Same thing I teach my students. If you're really good at your job, you prevent codes. That's when somebody actually dies in the field or in the ambulance or in the emergency room. You prevent people from dying and having to be resuscitated. Nobody will ever know you did a good job. But if you screw up and let them die and then bring them back, everybody says, great job. So we actually reward people, our psychology rewards people for waiting until things break instead of fixing them ahead of time. And that is something that we're going to pay the price for over and over until we learn from it.
yeah.
I'm aware, Paul, that we used up more of your time today than
Okay.
actually I would be willing to go till for whenever, because you've got a million more stories than you. So I would like you to have the last word. Where do we go from here?
Well, I think we kind of touched on that, Coffee, and your last comment, interestingly enough, actually defines our entire medical system, doesn't it?
Yeah.
In that we tend to have built our hospital and medical healthcare system in the United States and in the Western world around acute problems. And it's only been the last few years where we think about things like social determinants for health and disease, and to put some effort into prevention and training, and in an effort, in a hope that we can not see the kinds of individual devastation that chronic diseases result are the source of. And so, disaster response is not too dissimilar to the kinds of thinking that we need for the entire health system in the United States, and hopefully wiser people in more powerful positions than I'm hoping can see the light and maybe even begin some effort to get us there.
Well, I sure hope this is not the very last time I get to interview you. But thank you so much for your time today, Dr. Roth.
It was great having this conversation, Coffee.
I think Shelley's up.
What are we ready? Okay. What's New in Health and Medicine with Dr. Coffee Brown video and podcast is produced by Shelley Carney and Toby Eunice from the AGK Media Studio in the Land of Enchantment. Please take a moment now to subscribe and leave a great review. Then share this podcast with your family and friends so they can improve their health too. Thanks for listening.